I chose to talk about Parkinson's disease because we see a lot of it, and it's common. Holly asked me in the break room earlier, are we seeing more Parkinson's disease? And I said, you know, it's interesting you said that because to me it seems like we are. And I'm not sure if it's increasing in America just because of aging. That's my guess. But I think we're also seeing more of it because we're picking it up earlier. We're noticing the signs quicker. You know, years ago, if somebody came in with a pill rolling tremor and, you know, it was pretty easy to make that diagnosis. Well, you know, that's sometimes a late symptom in Parkinson's. And we're going to talk about that and the other symptoms and the causes of it and a little bit about the treatment of it and the management of it. But it's a terribly debilitating disease. All of you all have seen various stages of it in patients we've had here. And it can be anywhere from very mild to just profound, as you know. So I'm going to kind of go through, and I made some notes here off Wikipedia, which I use Wikipedia probably more than some of the medical sites. It's just an excellent source online for information. But anyway, I'm just going to go through a lot of this you'll know. Hopefully some of it you won't know, and hopefully it'll be helpful to you guys and our patients. I enjoy treating this disease because most of the time we really help people. It's one of these diseases that we can give a medicine for and really see an improvement in days. And that's gratifying to us that work with them. So what is it? What causes it? I want to talk about that first. The symptoms are shaking, you know, the classic tremor when patients have that, which we describe as a pill rolling tremor, which typically is this kind of a movement, like someone's rolling a pill between their thumb and forefinger. It's usually 4 to 6 cycles per second, that many per second. If it's a lot slower, it's probably not Parkinson's. So just the number of times they do that gives you a clue right there. The other symptoms we see is rigidity. These patients become rigid. We sometimes call it statue-like when it's really bad. Again, those patients are easy to diagnose. But again, we're interested in picking up the patients that come to us maybe with some other diagnosis, a broken hip, and lo and behold, we find out they've got Parkinson's. And we've done that a lot here, and we've really helped these people and their families. But the rigidity, and there are two types that we kind of test for on a physical exam. One is called lead pipe rigidity, and that's where we take the elbow and just bring the arm down like that. And, you know, it should move just fine. And patients with Parkinson's, due to the rigidness of their muscle tone, it's kind of like this. You have to put some force there before it moves, like a pipe made of lead that maybe would slowly turn. And the other physical finding is called cogwheel rigidity, and my wrist rotates just fine. In a Parkinson's patient, we're going to talk a little bit about the whys of this rigidity in a minute, but you get when you do that forcefully to the patient, it moves like that. You've got some resistance, and that moves a little bit, and then a little bit more, a little bit more. And those are two of the physical findings that we look for when we test for rigidity in the patient. The walking is an issue. Again, the classic patient that comes in with the slow, shuffling gait. It's kind of stooped over, easy to diagnose. But the just slowness of movement can be one of the earliest things that we see. And we might just blame it on getting older or dementia. But that can be one of the early findings of Parkinson's disease. On down the road, a significant number of patients do get dementia, Alzheimer's type disorder from the Parkinson's. What causes it, we don't really know. Basically, we just don't know. There's a very small percentage that runs in families. It's very small. 12% or so of patients, I think, with Parkinson's will have a first-degree relative that also had it. My grandmother had it horribly back when I was 10 and 12 years old. And the brand new drug called L-Dopa, which we're going to talk about, had just hit the market. Prior to that, there was nothing to treat it. And unfortunately, the drug by itself has terrible GI side effects, and she couldn't tolerate it. I saw her just progress as a kid until she became just basically rigid in a nursing home and died after years from something else, just totally rigid from Parkinson's, because back then there's really no good treatment for it. Obviously, usually occurs after the age of 50. It can occur earlier. Famous one, Muhammad Ali, the boxer, his symptoms started at the age of 38. Whether or not the repeated blows to the head caused it's debatable. Probably not. Probably he's just going to get it anyway. So what do we know from a physiological standpoint? What triggers all these things? I'm going to leave these for you to look at later if you want to. I just pulled some things off the internet. But we know the defect. There's an area in the brainstem, which all of you know. Not a great view, but side view of the brain kind of, and then the neurons all come together into the brainstem that then goes on into the spinal cord. The brainstem is a very important part of our body. Lots of neurons go through that brainstem. If you think about it, all these nerve cells up here in the brain, to get to where they're going below the neck, they've got to go through the brainstem. And so that's an area also that if somebody has a stroke, that a very tiny stroke in the brainstem can cause massive amounts of damage just because those neurons are so packed in there. But there's an area in the brainstem called the substantia nigra. Nigra means black, and when you look at it, I don't have a great picture, but anatomically when you slice through the brainstem, you can actually see this little rim that's black. Normally brain is gray or white, and so it's just little speckles. It's not very big, but dopamine is produced there. And Parkinson's disease is a result of not enough dopamine in the system. Dopamine is real important for you and me. It does a lot of things. Lack of it can cause depression, for one thing, we know that. It does a lot of other things. But in this particular case, it interferes with the proper nerve transmission from the nerve to the muscles. And when I want a muscle to contract, when I want to do this, the brain sends out a lot of signals, but basically two signals. It tells this muscle to contract, but at the same time it's telling this muscle to relax. Because if this muscle doesn't relax, I'm going to be like this. And basically that's what Parkinson's does. It disrupts that normal coordination of flexion and contraction in your muscles in the most basic sense. So you can see why these people have rigidity, they have trouble moving, and they develop also what we call a stone-like face, lack of facial expressions. Again, a lot of this is just based on the muscle issue there due to the nerve issue. Again, we don't know why. We know that overexposure to pesticides does have a higher incidence. We do know that Agent Orange that was used in Vietnam, that chemical which was a defoliant, a number of Vietnam vets had a significant increased probability of getting Parkinson's. But it's an actual death of the cells in the substantia nigra, so they can't produce dopamine. Which gets on to our treatment, which we use dopamine to treat it. And we'll talk about that. Talk about something else first. Another very important thing about Parkinson's is a dysfunction of the autonomic nervous system. And we take it for granted. You and I don't have to think about our autonomic nervous system because it's working in the background. It's like your computers. You may be, searching Google, but in the background your computer may be doing virus checking and all kinds of stuff that you don't know about, you don't have to think about, it's automatic. The autonomic nervous system for you and me works all the time, and I think the best example of that is when we stand up. We all take it for granted. Probably everyone in this room has stood up, quote, too fast. Things got black for a moment, and then we were okay. And what happened for whatever reason is that was a drop in your blood pressure, your brain wasn't getting enough blood to it, therefore oxygen, and you started seeing spots and maybe almost or did black out. What prevents that is the autonomic nervous system. When we stand up, a lot of our blood and volume just immediately drops down. Water runs downhill, so does blood. And so it goes to our legs, out of our trunk, out of our head, for maybe seconds, not very long, because the arteries in your legs tighten up. The autonomic nervous system makes those arteries tighten up to reduce the blood flow to your legs, and actually also to your splenic area, even your GI tract, because your body is preserving your brain. And the body will do anything it takes to preserve the brain. It's pretty cool. At the same time, the autonomic nervous system makes the heart contract a little bit harder. You have an increase in the force with which your heart beats, again, to get blood to the brain. And it may speed up the heart rate for a few seconds. So we don't even know it. All this is going on. Unfortunately, in the Parkinson's patient, the autonomic nervous system is also affected by the lack of dopamine. And patients are far more likely to have postural hypotension, stand up, pass out. I mentioned Tuesday, the worst patient I ever saw we had here years ago, and he was an elderly gentleman and a real cool family, and they brought him into the office several times because every time he stood up, he passed out. And sometimes he'd even have a hypotensive seizure, for 10 or 15 seconds. And he was seen elsewhere, and some things were tried, and nothing happened. And they were getting him out of the car in his wheelchair and just sitting him up in the wheelchair. He'd pass out and have a little jerking seizure for a moment. So, we checked him. His blood pressure was just a zilch. And we got him in here, and this gentleman, he was elderly. He had pretty bad dementia anyway. And some of you may remember him, but laying in bed, his pressure would be fine. And we would just elevate the head of the bed, about 45 degrees, and he'd pass out. You remember him? And we really helped him. By the time he left here, we helped him, and at least he could sit in a wheelchair without passing out. And he had profound Parkinson's. The gait, again, often shuffling, kind of bent over, stooping, very classic because of the muscle issue that they have. The other things, I don't really notice this in patients, but again, back to the autonomic nervous system, oily skin, excessive sweating, sexual dysfunction, things like that. On down the road, the patients actually can develop dementia bad enough that they'll have hallucinations and can actually develop a psychosis relating to it. The treatment is basically trying to replace the dopamine. It's all about the dopamine. Dopamine is a neurotransmitter, and the way cells talk to each other, nerve cells talk to each other is through what's called a synapse, and this is microscopic. And you've got the end of one nerve coming, and it's kind of rounded like this. And you've got the receiving nerve that's going to receive that nerve impulse. It's kind of like this, and they fit kind of like that. Again, this is all microscopic. And so the nerves actually do not physically touch. For a nerve to transmit from here to here, it has to pass something between the two ends of the nerves, and those are the neurotransmitters. And there are several of them, and dopamine is one of them. So at the end of this cell, you've got dopamine being produced here. It gets the impulse and it says, okay, I want to move my big toe. So it's sending that message to the muscle that's going to move the big toe through this nerve, and the dopamine goes from here to here. Everything works great. But again, with lack of dopamine in the body, that's lost. So the goal of treatment in the Parkinson's primarily is to replace the dopamine. So when my grandmother had it for years, they came out with a wonder drug called L-Dopa, and she couldn't take it. quite frankly, most people couldn't. Just nausea, vomiting, diarrhea, just kind of miserable. And also the problem is that when you swallow a pill of dopamine, only around 10% or so is actually absorbed and can get in doing good. So after a while, they came out with another chemical called carbidopa. So when you guys see Cinemet, and you have to write out that long word because it's all generic, it's levodopa / carbidopa, whatever. And the reason for that is carbidopa, it works to inhibit some of the enzymes that break down dopamine. So you've got this synaptic cleft, as it's called, and normally you've got dopamine going and doing its job. Well, what happens then? Does this nerve just keep producing more dopamine? No. The dopamine does its job, it's reabsorbed and recycled. Okay? So the way this carbidopa works, now to do that it has to be broken down, a lot of chemical things going on to recycle that dopamine. Again, microscopic here. So the way carbidopa works is when the few dopamine molecules the patient is making go over there, it does its thing, and they're floating around. What the carbidopa does is it reduces the breakdown of the dopamine that's there. So it not as much as being broken down, that leaves more left to work, and then that improves it. So with only 5 to 10% of dopamine that's in the blood gets into the brain. And there's something called a blood-brain barrier that we all have. It's incredibly important. And it's, again, microscopic, and it's something put in there because everything that gets in our blood, we don't really want it in our brain. Again, the body will protect the brain. And so many drugs will not cross the blood-brain barrier. And so you have to give bigger and bigger doses. Again, unfortunately, when you give those big doses, people get sick. So that's why by giving the carbidopa with the levodopa, you can get by with lower doses of L-dopa, and you're going to get an effect. So that's why we see that combination. There are other drugs out there. These drugs are called dopamine agonists. They just, in different ways, and there are different ones, try to make the dopamine work better. We won't go into those because there are several of them, but really not necessary to go into those today. Just to let you know that we do often add these agonists to the Cinemet. The other thing I want to mention about these patients, and we've seen it here and I've treated it here, is what's called the on-off phenomenon. And in these patients, because sometimes these drugs are short-acting, you can give them and say they're on it 3 times a day. You may see it work within an hour or two, and then before the next dose, the patient doesn't do as well. So in other words, their body is on and then it's off. So to do that, we just have learned in some patients, give it every 4 hours or whatever. There are extended release preparations out there now, and generally here I'll start the immediate release and then leave it to the primary care physician to follow up to decide, if they want to move up to the extended release. But it's finding the right dose for the right patient, and everybody is different. There are some real exotic things out there for severe patients. There's surgeries that can be done to go in there and enhance the effect of the function of the substantia nigra. And there are a few other drugs coming down the pipe that are not yet available too. And there's some other weird things that have been going on. So that's it in a nutshell. Questions?
Parkinson's versus Parkinsonism.
Good question. Yeah, everything that looks like Parkinson's disease is not necessarily Parkinson's disease. So there's this category of Parkinsonism, which is a patient that looks like they've got it, but they don't. And a good example I gave the other day was a gentleman we had in here. He wasn't very old, and he came in because rapidly progressive Parkinson's disease. And he was down in room number 5, I think. Nice guy, diabetic, overweight, and man, he was rigid. He was a classic Parkinson's disease patient. And so I looked at him and I thought, wow, it's really wild. Looked at his meds and sure enough, he was on Reglan. And Reglan is just kind of almost, I almost want to use the word notorious for causing Parkinsonism. It will mimic Parkinson's disease. This guy was on Reglan, we stopped it, and gee, and 3 or 4 days later, he was 50% better, and he walked out here just fine, you know, a week later or so. So it's real gratifying when you see that. Then again, some patients can have tremors that are not Parkinson's. They can have rigidity that's not. So generally, that's pretty much how I see the difference. Often drug induced.
What about stem cells for as far as moving forward?
Good point. Mentioned that Tuesday. Yes, they're researching that big time. I think stem cells are awesome. They're just amazing when you really get into it. I want to learn more about it, but that is something, I think they've tried it some, but I haven't really looked into it.
Parkinson's plus,
Plus, what's that?
it's more issues that they have going on.
You mean comorbidities or just more symptoms of Parkinson's, other symptoms? Yeah, the dementia. I've never seen somebody that gets like overly sexual drive. That's been reported. Other than that, I don't know. Well, let me see if I missed anything here. I don't want to read all of this to you.
Dr. Russell, besides Reglan, are there other drugs that commonly cause Parkinsonism?
Yeah.
Like antipsychotics? Or
Yeah.
There's a lot of.
Absolutely, the antipsychotics. I mean, they are notorious, especially the older ones. You know, Thorazine and those. Notorious. In fact, we just have to accept some of the, we call them EPS, extrapyramidal symptoms, which are, you know, the pill rolling, the rigidity, the stone faces. I go to 3 nursing homes, and unfortunately, a number of these patients are on antipsychotic drugs, risperidol or Haldol, and these folks eventually almost are going to get some Parkinsonian symptoms. And Sentiment doesn't work on that. You know, we try cogentin and things like that, and I'm not really impressed with it. So it's a matter of titrating how psychotic you want them to be versus how bad are the side effects. Yeah, good point.
So if sentiment works, it is Parkinson's.
Pretty much, and that is one of the diagnostic ways to make it. Yeah. There's no lab test for this. There's no X-ray. There's no MRI. The diagnostic test is try sentiment.
It works.
It works. It's got the diagnosis. Yeah, symptoms plus response to the drug, and that's why it's kind of fun. I mean, and it works quick. 2 days, you can tell the difference.
Good work, thank you.
You're welcome. Thank you. You got an easy group. You guys are easy. You don't throw